Okay, guys, so allergic reactions is chapter 20. And, this is anywhere between food allergy, anaphylactic, from a bee sting, multiple different situations that we're going to discuss real quick. It's not a very long chapter, so it won't take a whole lot of time, but we just got to get through it. So, allergic reactions is the immune system's natural response. Anyways, so when we have allergies, it's really just our immune system working overtime, from seasonal allergies to whatever. So when our body naturally responds to foreign substances in the body, this is what we would call an allergic reaction. So anytime your natural immune system fights off the flu, viruses, bacteria, responds to the foreign objects in our body, we have our immune response. Allergic reaction is when it's exaggerated response to foreign substances. So we have our natural ability for our immune system to fight normal things, but when it's exaggerated, to that foreign substance, it becomes allergic reaction. So sometimes when we have allergies to seasons or whatever, our immune system might be working overtime, and that's why we feel the allergies. But when it's exaggerated, it becomes an allergic reaction. So an allergen is the substance causing exaggerated effects. So the allergen would be the pollen, it would be the bee sting, it would be the crawfish that you're allergic to, many of those things. So inside is how one of the ways it works, the first exposure. So you don't have allergies to something, you're not allergic to something until you're exposed to it. So you might have an immune system, an allergic reaction to peanut butter, for example, but you do not have those, you're not allergic to it until you're exposed to it, if that makes sense. Because your immune system forms the antibodies then that attacks that. So antibodies identify and attempt to attack particular foreign substance, from the peanut butter to the bee sting. You don't have those antibodies built up until you're exposed to it. Just like that's why you get a flu shot. You get a flu shot to create the antibodies or put the antibodies in your body to fight that virus, so you can hopefully fight the flu when it comes. That's one example. But antibodies identify and attempts to attack particular foreign substance. Antibodies combine only with allergen they were formed in response to. So the antibodies they combine only with allergen that they were formed in response to. So they're responding to the peanut butter, to the bee sting, to whatever that case may be. Read your book on this section because it will be a test questions on the first exposure and all that. Second exposure, the antibodies exist. Antibodies combine with the allergen, leading to release of the histamine and other chemicals in the bloodstream. So that's where the allergic reaction begins. I knew a guy who had such an allergen. Actually, my daughter is one of them. She has such a high histamine rate that you can take your fingernail and barely touch her skin with it and right on her arm or her back, and it'll swell. And you'll see exactly what you wrote. Her histamine level is that high. So that's because the antibodies are overactive, and then it causes allergic reaction. So chemicals cause harmful effects. So it's kind of funny because it's what's designed in our body to have an immune response to help us fight off infectious diseases and all that kind of stuff, but also kind of works against us in some areas. So the outside effect of the histamine and other chemicals is inflammation, like I said with my daughter, when you can run her skin. But that can be on the outside. Your eyes swell, your tongue swells, your lips swell, your skin swell. I mean, just overall. But the problem is then you also get the bronchoconstriction, so your airway swells, vasodilation, which is your arteries, arterial walls, they swell or dilate. I'm sorry, and it causes a decrease in your blood pressure, so you become hypotensive. So you see the effects here is the inflammation of the swelling, your bronchoconstriction, so your airway narrows, but then you go hypotensive as well. Anaphylaxis is a severe life-threatening allergic reaction. So it's just the severe case. So your rapid dilation of blood vessels, so hypotension, which we just said. Your airway swells up, so you have the airway obstruction now. Your airway is no longer patent. All anaphylactics we count as airways not patent. And then your bronchoconstriction leads into a respiratory failure because it can close up. Common allergens are, insects from bee stings is the most common that I've seen. Um, I know people also have an allergic reaction, not anaphylaxis, but they have an allergic reaction to mosquito bites. I mean, we all get irritated by them, but I've seen people actually have a rash, swelling, all that. Certain foods, peanuts, peanut butter, seafood, all that kind of stuff. Plants, certain plant life. I'm a severely, when I was in Michigan, I had allergies all the time. I never had anaphylaxis, but I was allergic to all the trees and green and all that. But people have those plant situations, medications. And again, you don't know you're allergic or you're not allergic till you're exposed. So when doctors ask, are you allergic to any medications? Well, if you've never had any, you don't know, right? But there's people that absolutely have a horrible response to some medications and will lead to anaphylaxis as well. Dust, makeup, soap, etc. There's some pictures, the insects, the plants, prescriptions, seafood, peanuts. Latex allergies is a common one. Definitely need to be concerned about as in EMS. Latex sensitivity. And actually, the truth of the matter is really, if you're over exposed to latex, eventually we're probably going to have some kind of irritation to it. But some providers cannot even wear latex at all. No way to predict the exact course of an allergic reaction. We just don't have a way to predict every single allergic reaction, how it's going to respond. So a severe reaction often takes place immediately. The person that eats the crawfish, and instantly their bronchoconstriction begins. Then there's some that take up to 30 minutes. I saw an anaphylaxis one time that was exposed, and it was about 30 minutes later that she was really getting symptomatic, so we had to move fairly quick. Mid-allergic reaction, so someone that's just a minor exposure to something, or they don't seem critical, they can go to an anaphylactic really quick. So we want to monitor them, we want to watch them, keep them on the vitals, keep those vitals coming so you can watch the trends to see where they're heading and if they go to anaphylaxis. Signs and symptoms. Your skin becomes itchy, hives, flushing, red, swelling of the face, warm, tingling, feeling the face, mouth, chest, feet, hands. So all those things can happen, like that picture right there. That's definitely, a pretty severe allergic reaction. And the main thing is if that's on the face, what's going on with the airway? Obviously he's not on oxygen, so they obviously prove nothing's wrong, but something to consider and monitor. Another example here is the hives. I've never had hives, but I've seen a lot of it. The truth is actually there's a lot more people allergic to wheat in our area than admit it or know it. During harvest, I see a lot of different respiratory issues taking place, and it's just the way it is. It's in our air. When wheat harvest begins, it's in the air. You got someone that's allergic to wheat, they're breathing that stuff in. Respiratory, the tightness in the throat or chest. So again, the constriction begins, the airway begins narrowing, the chest pressure, cough, rapid labored and noisy breathing. I will get this way a little bit during wheat harvest because I'm allergic to wheat in some ways, and so I get coffee and not coffee, but coughing and noisy breathing a little bit at times. Hoarseness, muffled voice, loss of voice, stridor, which is the whistle sound, right? And then wheezing. Now the cardiac part is basically increased heart rate and decreased blood pressure. So again, it's allergic reaction, right? So the vasodilation, the arteries dilate, so it decreases that blood pressure, and the heart rate's going to pick up, and so you got tachycardia with hypotension. Generalized findings, you'll see the itchy, watery eyes when you're looking at patients. You'll see headaches, runny nose, sense of impending doom. So always take the impending doom. I said this before. Always take that seriously when someone feels, they say, oh man, I don't feel like I'm going to make it. I feel like I'm going to die. Their body is going through a traumatic experience, so listen to them on that. Like I said, there's always a chief complaint. There's a chief complaint the patient says. Doesn't always mean it's the real chief complaint, but if it's a concern to them, it's a concern to you. So the generalized findings that you'll see right away is the itchy, watery eyes, headaches, runny nose, and a sense of impending doom. So the shock part of this is just, shock is a severe thing that we've talked about in many different chapters, altered mental status. So again, if they're hypoxic, they're not getting all that airway moving, their flush, dry skin or pale, cool, clammy skin, they're going to be nauseous, sometimes vomiting, and they're changing vital signs. So the increased pulse, increased respirations, but decreased blood pressure. So their body, anytime there's anything increased, their body's trying to compensate. So the pulse rate rises, the respiratory rate rises, but their blood pressure is tanking. Doesn't have to take a lot either, just a little bit. You want to take seriously. So it's a sign of shock. So when you have anaphylaxis or allergic reaction, you get them on the monitor right away, make sure that airway's patent, but then watch to see them going into a shock realm with these signs and symptoms. So any of the previous signs and symptoms can be associated with allergic reaction. So anaphylaxis, the patient has either respiratory distress or signs and symptoms of shock. Okay, so a patient has either respiratory distress or signs and symptoms of shock. So when you do the assessment, you identify and treat life threats, right? Airway, ABCs. Obviously it's ABCs. Why? Because they're not dead. If they're in cardiac arrest, it's CBA or CAB. But airway, breathing, circulation. So if their airway is closing up, that's an immediate life threat you got to take care of. And then check their circulation, check their pulse, check their skin temperature, check their cap refills, in the foot and the hands, check all those things, and then check their vitals. Secondary assessment. Main thing I want to say on this too is it's just like any other assessment. You're doing your assessment, see a life threat, stop, take care of that life threat, and then continue on with your assessment. Secondary assessment is history of allergies. Get that sample, get that OPQRST, history of allergies, exposure. What was the patient exposed to? How? What method route was the patient exposed to? So what was the patient exposed to? So exposure, what was the patient exposed to? Plant life, food, bee sting, and then what route was exposed to? Was it sublingual? Was it skin? The route is in your book, and I want you to really read that. I don't actually have a book in front of me at this time, so I apologize. I'm in my class in the Springs and just on break real quick. But I want you guys to look at the different routes they talk about in your book, because there's sublingual and there's skin, there's blood. Take a look at that and look at their signs and symptoms. Tachycardia, bradycardia, everything we've read so far says if it's allergic reaction, they're going to be tachycardic. So that's a sign that they're having an allergic reaction, right? Because the truth is, when you first got on scene, before you begin your assessment, you don't know if it's an actual allergic reaction. You can't base everything on the page, on dispatch. So when you begin your assessment, if they're tachycardic, if the respiratory rates are, if they're bradycardic, that's a sign of an allergen. And then if their blood pressure is lowering, that's a sign of an allergic reaction. And then interventions. Take those interventions that you need to help the patient's outcome. Assess the baseline vitals, like we said repeatedly. Get that baseline so you can follow trends. Obtain remainder of past medical history. Is this normal for you? Have you had this before? Did you know you're allergic to whatever you're exposed to? Has this happened before? Did you know that you're allergic to bees? And go from there. Again, because you got to look at their situation now, in this very present time, with their history. Is this abnormal or normal compared to their history? Manage patient's airway and breathing. Apply high concentration oxygen if patient is in distress or appears to be having an anaphylactic reaction. So if they seem to, if they're having difficulty breathing and they seem to be going anaphylactic, throw them on high concentration oxygen. Non-rebreather, 15 liters. Mid-allergic reactions do not require oxygen. So if they're just a mild case, they may have a rash on their skin, but their airway's patent and they're not in distress, don't give them oxygen. Not everybody gets oxygen. But if they are having difficulty and you're seeing the signs of anaphylactic, put them on that oxygen. If not breathing adequately, provide artificial ventilations. So look at the fact, if they're not breathing, getting good ventilations, right, in, out, Their lungs ain't expanding. They're not filling up their lungs. They're not getting that alveoli to drop off gas and to pick up good O2 to the body. They're not going to perfuse. So begin thinking about breathing for them. Patient's care. Consider assisting patients with an epinephrine auto-injector. So in your book, you're going to see the auto-injector. Test purpose auto-injector. Do not worry about what we do in our scope of practice, which is with the vials, auto-injector. So if a patient is not wheezing or showing signs of respiratory distress or shock, continue your assessment. Don't stop to intervene with anything if they don't show those things. Continue your assessment. Consult medical direction regarding use of an auto-injector if they have it. Because the truth is, you don't necessarily need to give an auto-injector if they're not in anaphylaxis. So consult your medical advisement. If the patient is not wheezing, they're not showing signs of respiratory distress or shock, you got to gauge your judgment on that. Continue on to their assessment, contact medical control. When use of auto-injector may be appropriate, the patient has come in contact with substance that caused allergic reaction in the past. So this means that they have a history of it, they know they have a history of it, and they got an EpiPen. Okay, so they know their history. So if they got stung by a bee currently, and in the past, they've been stung by a bee and they had to seek a medical advisement and they got better and they know the situation, you may want to use an auto-injector. The patient also has respiratory distress or exhibits signs and symptoms of shock. Obviously then, boom, you're going to attack that, right? So after using your auto-injector, record administration of auto-injector. You got to record. So as soon as you give any kind of medication, we've said this, you note it. So boom, auto-injector in, 2:15, you note it in your report, 2:15, auto-injector was there, and then you reassess after 2 minutes to see if there's improvement. So perform your reassessment, paying special attention to the patient's ABCs and vital signs en route to the hospital. So the main thing there is, like I said, if you give the epinephrine, you now have to note it, give 2 minutes, reassess, remonitor those vitals, secondary assessment. So again, based on what we just discussed, should you administer an auto-injector for a simple allergic reaction? Think about that. Think about it, and then talk about it with someone around you. Basically, I don't know. I wish I was with you to talk about this, but the simple fact too is, we just discussed it. So if they're not showing respiratory distress, they're not showing anaphylaxis, and they're not showing shock, you don't necessarily have to seek medical advisement. But if they have a history of it, and they're showing the signs of it, boom. What assessment findings would indicate the need for an epinephrine? Right? Tachycardia, respiratory or bradycardia, low blood pressure, narrowing of the airway, right? The bronchial constriction. So they're showing signs of anaphylaxis and shock. I wish the video worked, but again, on YouTube, go there, allergic reaction anaphylaxis video, watch it. It'll help. It's a good thing. Plus on the website that we gave you earlier for all kinds of tools, they have these kind of things. Self-administered epinephrine. So commonly prescribed to patients with a history of allergy. So if they have a history of this, they probably have their own EpiPens and they're prescribed because it's a life-threatening issue. They know they have it, right, because they've been exposed, so now their antibodies are kicked in, and when they're re-exposed again, it can flare right up, so they got a prescribed auto-injector. They carry it at home, they carry it in the cars. Hormone produced in by the body, self-medicine. So read the chapter on this. There's hormones produced by the body, constricts blood vessels, dilates bronchioles. Base allergic reaction. If authorized by medical direction, you can minister or help patient administer dose of epinephrine from the auto-injector that has been prescribed to patient by a physician. Again, for test purposes, follow this. For us, we're waivered. We don't have to seek medical advisement, but I recommend it before you give an epinephrine. Just because for a while, you guys will be rookies. Nothing bad. I'm still a rookie in a lot of areas. I'm not experienced in every area, so trust me on this. So the main thing is it's just something good to do to cover your butt, but we're waivered. For test purposes, you have to seek medical advisement. Side effects, they're going to be tachycardic, and their cardiac workload is going to increase. So go back to your cardiac chapter, read the cardiac workload, read these parts of what that means. And basically, a side effect is they're giving epi, so you're getting them adrenaline. So boom, the heart rate's going to go up and everything's going to be kicked in. So administering an auto injector is a spring load needle. You can see it in your book. It's basically a spring loaded needle and syringe with a single dose of epinephrine. So it's not like when you draw up an epi, you can give a couple doses out of one vial unless you make a mistake. With this, it's one dose. That's $800 for one EpiPen for one dose. But you inject it, you just put it in, the spring loaded medication automatically releases and injects. And we'll play with some. I got some tests and when we get to class. In class time, I have actually some class purposes epinephrine we'll play with. Administering auto-injector, so obtain patient prescribed auto-injector and ensure prescription is written for patient, right time, right dose, right route. In the chapter, in the pharmacology chapter, prescription is written for patient, medication is not discolored, and medication has not expired. Obtain order for medical direction, remove the safety cap, and then press tip of the injector firmly against patient's thigh outside of thigh midway between the knee and waist. So mid, above the knee, right in the thigh, right in the middle. Press it against, hold the injector in place until medication is injected. It's spring loaded, you'll know. You'll hit the leg, boom, and you'll hear it stab in and inject. Only takes a second. Administering auto. So record and administrate the time. So 2:15, epinephrine was given. Carefully dispose of single dose injector in a biohazard container. We carry them in ambulances. Save two dose injector. Some of them have a 2-dose injector, so you want to save that, but get rid of the waste. The reassessment may show patient condition deteriorating. So as soon as you give it, right? So you give the dose, you note the time. 2 minutes later, you reassess, do a whole another vital scan, and then maybe they're deteriorating. Additional doses of epinephrine may be necessary. I gave 2 doses last time before things reversed into a good direction. It requires online medical control, require bringing patient additional auto-injectors and ambulance. So you just may need to bring more, right? So you get a hold of medical control again. Like I said, we're waivered, but I just highly recommend it for you to do. And then require bringing patient additional auto-injectors into the ambulance if they have more. If no auto-injectors are available, get on the horn, request ALS intercept, and then treat for shock. So what we can do is in our department, if you run out in the ambulance, I have, in the primary ambulances, I have plenty stocked. I'm restocking our secondary ambulances. You should not run out unless you make a mistake, and it happens. I've done this myself. I made a mistake one time giving epinephrine, spilt it. I had a deputy have to go to the hospital. I called medical control, said I've got a deputy en route. Can you give me some epinephrine to bring back? And it worked out. So request the ALS intercept. That's kind of what that could be for us in Cheyenne County. Treat for shock as you're moving forward. Oxygen, take care of them. There's 2 doses of auto-injectors. So for an adult, it's 0.3 milligrams. For children under 66 pounds, it's 0.15. Whether you have an EpiPen or you draw it up, that's what it is. So probably a lot of questions. I breezed through this pretty quick, and it's a basic chapter. I mean, it's not very complicated. Just read your chapter, do your homework, bring questions with you. But allergic reactions are common. Anaphylaxis is a true life-threatening allergic reaction. If you get a page out for an anaphylaxis, do not take your time getting to them. The most common symptom in these cases is itching. Anaphylaxis will also display life-threatening difficulty breathing, signs and symptoms of shock. Patients with anaphylaxis will be extremely anxious. Their bodies are in trouble, and they're letting them know it. And so they're anxious, impending doom. That impending doom is not just a thought. It's not just, oh, I'm paranoid. It's their body going through a traumatic experience and letting them know this is serious. The signs, excuse me. The signs and symptoms of anaphylaxis result from physiological changes: vasodilation, bronchoconstriction, leaky capillaries, or thick mucus. So, excuse me, guys. The signs and symptoms of anaphylaxis are results from physiological changes. So there's the vasodilation that we talked about, right? That's going to cause hypotension, bronchoconstriction, which is going to cause respiratory distress, leaky capillaries, and thick mucus. All that is what causes anaphylaxis. So when you look at that, if you can memorize this and learn it for the test, but also know that's what you're intervening with when you're on scene. That's stuff that you're taking care of. So by quickly recognizing the condition, you consult medical direction, you administer the appropriate treatment, and you can literally make a difference. I mean, that's just facts, is that everything's going south, you intervene with the right medication under medical advisement, you can actually, if it's an anaphylaxis, you will be saving a life. An allergic reaction, the body's immune system overreacts. Okay, it's an overreaction to the allergen and causes potential harmful side effects. It's your body's immune system over exaggerating. And anaphylaxis is a severe symptomatic form of allergic reaction. It is a life-threatening emergency. So the fact is it's severe. It's your body's immune system overreacting, and it's a symptomatic situation that causes life threats. And so when you get on scene, from your assessment, everything you're doing is you're going to be intervening with these life threats. And that's really what it is. The EMTs must use assessment to differentiate. Okay, so remember, you must use your assessments to decide a localized reaction from a symptomatic anaphylactic reaction. Okay, so you got to decide between, okay, this is just a localized allergic reaction to the arm that was stung or the face that was affected by the environment, or an anaphylactic reaction, which is everything kicking into gear. So there's two different kinds of allergic reaction. Localized, which is just where the exposure happened, or anaphylactic, which turns into a respiratory global kind of situation. Epinephrine, obviously, is used for anaphylaxis, and it constricts dilated blood vessels and opens bronchial passages. So the epinephrine will actually open up the airway and constrict the dilated vessels. So the respiratory area will open up, so they can breathe by opening that area, but then it constricts those dilated vessels so blood pressure can go back into a normal range. Get the patient out of a hypotensive state. Okay, so hopefully that makes sense. But the main thing is you guys always got to know when you got allergic reaction. Localized, anaphylaxis, epinephrine. If it is anaphylaxis, epinephrine will dilate the bronchial openings, the bronchial passages, and it'll constrict the blood vessels and bring the hypotensive patient back into a normal blood pressure rate. Epinephrine obviously can be dangerous side effects, so you got to continually be monitoring and just go through these questions. What are the indications for administration of epinephrine autoinjector? So you got to have to know that for test purposes. List some of the more common causes of allergic reaction. What are the main issues that people deal with? And then I want you guys to list signs and symptoms of an anaphylactic reaction associated with each of the following: the skin, respiratory system, cardiovascular system. I want you to write these down, and we're going to do it in class. Okay? So we don't have class tonight, which is Wednesday, but Monday we're going to open up with stuff like this to make sure that you guys not only read the chapter and listen to this teaching, but that you're absorbing this. Okay? So critical thinking: a 24-year-old male ate a meal that he believes contains shellfish. He is allergic to shrimp. He is sweating and nervous. He appears to be breathing adequately. You do not note any wheezing or stridor. His face is slightly red. His pulse is 88 strong and regular. Respiration is 24. Blood pressure is 108/74, and skin warm and moist. Should you administer epinephrine? What do you guys think about that? Read that, process it, and we'll talk about it Monday. Okay? So appreciate it, guys. This is it was only wasn't a very long slide, which is good. We have some long chapters and some good ones like this. So I'm gonna get the others uploaded as I can. I'm in class today, and I'm late from my break, so I want to get this done for you. So take a look at this, do the homework, read the chapters, do the best you can to get this in your minds, and we'll discuss it Monday. Thanks, guys.